Good morning, everyone. We'll get started in a little bit. Just going to let people join and we'll get rolling. Okay, good morning, everyone. Just to be cognizant of schedules, I know everyone's busy. We'll get started. I'm sure people will join as we go along. Um, we're lucky to be able to put together some coding education. Dr. Nasser and Dr. Little have worked with me in trying to get some things started, and we're lucky to have Renee Lacasse join us to present to us over the next couple of months some clinical coding, surgical coding, fracture coding, and we were just talking about some additional changes that are coming up to CPT codes in 2026. We'll add another session for some of the changes that are coming up with that. But we're lucky to have Renee present to us today. Renee is the coding and auditing educator for Tenet Healthcare across the system. And so I'm going to turn it over to her. Appreciate your time today, Renee. And I know she's got a lot of information to share. So you can start whenever you're available. So thanks again, Renee.
Thank you. Good morning, everyone. As said, my name is Renee. I am one of the coding educators for the Detroit market. I have technically been working for the Detroit market for 3 years, but have been in coding and education for over 20. As said, I am actually here today to provide some education and support on key coding topics. Over the next couple of months, we will go over evaluation and management guidelines, surgical documentation and billing standards, and most importantly, fracture care. And we, as discussed, we are talking about doing another session to go over the 2026 guideline changes that will be coming up in January. But for today's session, we will be focusing on E&M guidelines to help you understand the requirements and best practice for accurate documentation and compliance. We will have a lot to cover today. So the one thing I am kindly going to ask is that you allow me to get through the entire presentation. And then, at the end, I will give you an opportunity to ask any questions. So the agenda for today is actually going to be topics, and we will review billing for MDM or time, along with diagnosis sequencing. We will identify new versus established patients, when to use modifier 25 and 59. We will go over what a shared visit is and the role of the teaching physician with residents, chart completion and orders, and the last part of the presentation will include some valuable information as well. So when we look at evaluation and management coding, they went to, under significant revisions back in January of 2023, which continues to shape documentation practices. All clinicians now follow a unified set of guidelines, and the E&M level is now determined by either total time spent or your medical decision making. You may not combine both of these. You have to bill one or the other. Your HPI, your review of systems, past family and social, along with your physical exams are no longer used to select the E&M level. Instead, your documentation should focus on pertinent details that reflect the complexity of the encounter. The expectation to this is the emergency room department visits. as they solely rely on MDM and they cannot bill by time. So when we look at this right here, this is a graph and this is what makes up the medical decision making. And it is a part of the component in a clinician documentation and coding that reflects the complexity of a provider's thought process when diagnosing and managing a patient's condition. It is used to determine the level of service for the evaluation and management visits. The MDM level is based on 2 out of 3 elements. What this means is you need to meet 2 of these categories out of the 3 in this list, and they must be documented clearly. Number and complexity of problems addressed. This right here refers to the type and severity of the patient's condition. For example, a single self-limited problem, it would be considered a low complexity, while multiple chronic conditions with exacerbations are considered to be higher complexity. Then you have your amount of data reviewed and analyzed. This includes reviewing labs, images, external notes, orders of testing. The more data and the more, which means the more complexity, for the interpretation in the higher level. Risk and complications. This is about the risk associated with the patient's management decisions, such as starting high-risk medications or deciding on surgery. So these are some charts that we actually go by when determining your level for your MDM. If you look over here, you have your levels here, your straightforward, your low, moderate, and high. In this column, you have your complexity of problems that you addressed. These would be your diagnoses that you're going to be treating. Then you have, of course, your data and, your data or your orders, and then you have your risk of complications. So if we look at problems addressed, the number of problems addressed, you will see here in the moderate section, you actually have 1 undiagnosed new problem with uncertain prognosis. Now, this is probably going to be somebody that's coming in as a new patient, complaining of a shoulder pain. You don't know until you treat the patient what the total, what the primary diagnosis is going to be. But you right here alone would bring your complexity of problems addressed to a moderate level. And then over here, you've got your data. Now, say you order an X-ray. Here on your data, this is a little bit tricky. So when you look here on data, a lot of providers get this kind of confused. When you look at the low here for a limited, you need to meet 1 out of the 2 categories, meaning you need to have 2 out of category 1, or you have to meet the category 2 to get a limited in your data. And then over here, this is the same thing. So if you look at moderate, you have prescription drug management, decision for a minor surgery, and then something over here as far as for your high would be something, you're monitoring a patient that requires intense monitoring for toxicity. Example, chemotherapy, immunosuppressants, anticoagulants with narrowing therapeutic windows. Risk factors, cardiac surgery in a patient with severe comorbidities. So in order to use this tool and how to determine your level, if you have a new patient that comes in with, say, shoulder pain, right there, your shoulder pain would be a new problem addressed. So that falls under a moderate. You order an X-ray. Well, here, review of external records, you'll see review of results or ordering. You're only ordering 1 X-ray. So you do not meet 2 out of this following category. So you would actually bump yourself to a minimum or none. And then you decide, okay, that the patient, needs prescription drug management. So here you'll have a moderate. So the way this works, we have a moderate for, the complexity of problems addressed. You have minimal to none for your data, but then you have a moderate risk because of the prescription drug management. You need to meet 2 out of 3. So you got the moderate here and you got the moderate under risk. That gives you 2. So that would actually bring your level to a level 4 for either a new patient or an established patient. I also included the examples here because I will send this slide sheet over, this slide deck over after we're done, and it can be kind of used as a tool for you guys in guidelines. But here you have your E&M leveling for inpatient and observation for your initials. And then I also included the subsequent inpatient and observation E&M levels. On this here, this goes over, this is to help outline actually the count for ordering and tests under the data. Credit here is given for either ordering or reviewing each unique test. If a test is ordered during an encounter, credit is applied to that encounter, meaning that if you order it on that day, you're going to count that order. You can't count it the following day when the patient comes back. Reviewing, if the same physician or group specialty orders and reviews the test, the review does not count separately. For example would be, patient seen in the orthopedic office and an order is placed for the x-ray. You review those x-ray findings with patient during the visit. The order and review is not counted under the data. And the reason being for that would be is because we will be billing a CPT code for that x-ray. And this applies whether the review happens on the same day or at a later visit. What does count for a unique test? A panel of labs is considered one unique test. So that means that if you order a panel and you review all those labs, you can only count the ordering of it once. Reviewing multiple results of the same test, example would be your blood glucose levels. Patient brings in his lab work for the last 5 months. Even though you're reviewing all 5, you only get credit once for reviewing it. Tests that with overlapping elements are not unique. Lab tests with their own CPT codes are considered unique. So for example, that would be, a CBC and a urine culture. Each of those have their own CPT codes. So if ordered, they would count twice. You're counting one for the CBC, one for the urine. But if you're reviewing a CBC results, that only counts once because it's one unique test. Reviewing all notes from one source counts as one unique documentation, meaning patient outside records, for example, patient has all records sent and they include, cardiology, orthopedic. And even though you are reviewing both specialties and because they're subspecialties, it still only counts once under the reviewing. Now we're going to get into time documentation. When documenting by time, you want to record the total time spent on the date of that service. This also includes any activity you do prior. So reviewing the records, outside records before seeing the patient, during the visit, and after the patient encounter. For example, you're putting in orders or referring a patient to physical therapy. That all is included in your time. What isn't included would be time spent, from a medical assistant. The medical assistant rooms the patient, does some reviews. That would not count towards your time. Anything unrelated like teaching or administrative tasks. It is important to note that CPT in 2025 updates require meeting or exceeding the minimum time listed for each code. Accurate time documentation is crucial. It is crucial for compliance and reimbursement. What is not acceptable would be documenting that you spent greater than 45 minutes with a patient. You need to make sure that you are giving the exact total time that you spent with that patient. And then here just goes over more as to what is pertaining, reviewing your previous records, like I had said, documenting in the EHR, calls with results, calls for prescriptions. But remember, this also has to be done and it has to be performed on the same date of the visit. Here is a slide sheet. This is a reference sheet to help when selecting your CPT codes by time. You must spend the duration of that that particular CPT. It is important to note that not all codes have typical times. Example would be your ER visits. In such, time may not be used to select the code level. When selecting time, the provider must have spent a time closest to the CPT code. For example, if you document that you spent 40 minutes with a new patient, okay, you'll see right here, 45 minutes for a new patient on a level 4 is 45, but you spent 40 minutes. That is more than half of the 45 allot amount. So you would actually bump it to the 45. We also have these add-on codes that also pertain, and they belong with your E&M codes. So this here is for prolonged services. So it's when you spend, patient care is significantly exceeds the typical time for the E&M service. So the only time that these codes would be used is if you are using the highest level. For example, you're billing a patient, an established patient, 99215 in the office, but you spend more than the allotted time for that. You could add one of these CPT codes. They're an add-on code to that time, and they are based on 15 minutes increments, meaning that, so for example, an inpatient, a 99223, that is a 70-minute visit, but you actually spend 88 minutes with the patient. And if you are documenting this information, you could bill your 99223 along with your 99418. Because you're over an extra 15 minutes over the allotted 70 minutes. So if you do say 120, you would add by units. So you would add an extra, 3 units of this 99418 to allot and account for your time. Diagnosis sequencing. This is the process of rearranging and reporting multiple conditions documented during a patient visit. We need to ensure accurate coding and billing. Providers must sequence their diagnosis codes to reflect the primary reason for the encounter, from the chief complaint through the assessment and plan. Coexisting conditions should be listed as the primary diagnosis, maintaining consistency throughout the chart. While ICD-10 codes for quality measures may auto-populate in our EHR systems, for example, your BMIs, providers should reorder them if they first appear, but do not represent the main reason for the visit. So because my understanding is a lot of when the MAs do their documentation and see the patient first, the Z codes are linked because they have to put in those BMIs. We need to make sure that that BMI is sequenced outside of the first order, because when we submit this claim, if it goes over with the Z code for the BMI as the primary diagnosis, the insurance is automatically going to spit it out. So you want to make sure that your proper sequencing is essential, okay? And it reflects the medical necessity to support the documentation, and help prevent claim denials. Remember that CPT code determines the payment, but the diagnosis code justifies the service provided. Accurate sequencing ensures both clinical relevance and reimbursement for compliance. This is an outline for enhancing your diagnoses to be more specific. Why specific? Specific documentation matters. Accurate and detailed diagnosing documentation, obviously is essential for compliance. It is also essential for reimbursement. Insurance companies are increasingly diagnose driven and will not accept unspecified codes. Using the highest level of specificity ensures proper claim processing, reduces denials and delays, and improves patient care documentation. You should always select the most specific diagnosis code available. Avoid using unspecified codes unless it's absolutely necessary, and review documentation guidelines and stay current. Remember, specificity is not just a requirement. It does protect the revenue and it supports the quality care. Now, here is an example of congestive heart failure, for instance. if you just tell us that, and I know you guys, a lot of you guys are pertaining towards orthopedic, but this is just an outline. So congestive heart failure, if it is used and it just states congestive heart failure, for example, we have as coding have no other way but to use the congestive heart failure unspecified. And I can tell you right now, the majority of our denials that we do see on a monthly basis is because of diagnosis coding. With congestive heart failure, they are looking, they want to know the type of failure. They want to know, is it systolic, diastolic? Is it combined? Is it right, left? Is it chronic, acute? The more information that you put in your assessment, the better off we are with reimbursement. And it will help, improve the denial factor. So accurate key points here to determine whether a patient is new or established. Obviously, a new patient is one who has not received professional services from a provider of the same specialty and specialty group within the last 3 years. An established patient has received such services within the time frame, meaning that they have been seen within 3 years. Important notes here, your APNs, your physician's assistants, working with physicians are considered to share the same specialty and subspecialty. And CMS does not recognize all subspecialties defined by the AMA. Therefore, the providers must follow the CMS definition when coding. To assist with this determination, a decision tree is available. Be sure to consult it when unsure. It can help ensure coding accuracy. And so here is your decision tree. Right here will tell you, has the patient been seen and evaluated by a provider or another provider within the same exact specialty or subspecialty? If it's no, then obviously you're going to follow this to a new patient. If it is, providers, are they the same specialty? Yes. Okay. And then so you'll follow here. Providers are the same specialty. Yes, and that would determine, and it would tell you that it's a new established patient. If they are not of the same specialty, it tells you right here to bill as a new patient. This tool can be very helpful. Modifier 25, this applies to significant separate identified E&M services performed by a provider on the same day as another procedure. It should be used only when documentation supports the additional service. So an example would be a patient comes in for a scheduled wart removal. During that visit, the patient is also complaining of new onset chest pain. The provider decides to perform a detailed history, exam, and medical decision-making related to that chest pain, which is above and beyond the pre-procedure work for the wart removal. So here they could bill the 99213 for the established patient, the procedure code for the discretion of the wart removal, and then we could append the modifier 25 to the E&M. The modifier signifies and separately identified from the wart removal procedure. Both services occur on the same day by the same provider, but you must remember when you are doing this, you must link the diagnosis for the chest pain to the E&M service. We cannot link the wart removal to that E&M, or they will deny it, stating that it's bundled and inclusive. Here is a decision tree for modifier 25. In this here will, walk you through, was it planned procedure? And if it, yes, is the E&M service related to the reason for the procedure? Yes, then typically we cannot bill for an E&M. If it's not, then it asks you, does the work of complete the work separate? Yes. And then you could go ahead and it will walk you down telling you that you could bill for both. This will be helpful as well, because I know some people can struggle with this. Modifier 59, this identifies procedures or services that are not typically reported together, but are appropriate under specific circumstances, such as different sessions or anatomical sites. Misuse of these modifiers can lead to claim denials. Providers must ensure documentation supports the distinct nature of the services and use more specific modifiers when available. So an example would be for this: a patient is going in for a colonoscopy with a biopsy. And then now, also they're doing a colonoscopy. When they get in there, they do a colonoscopy and remove the polyps by a snare technique. Normally, these procedures are considered bundled, but they occurred in different, while they were during the same colonoscopy, they do, they decide to do a removal of a lesion in the ascending colon. And the polyp was also removed in the sigmoid colon. They are considered two separate distinct anatomical sites. So we could append the modifier 59 to distinguish the two. Split shared visits. These visits occur in the facility setting only, and when a physician and another qualified healthcare profession jointly provide care on the same date. CPT coding guidelines align with CMS, so we have to follow them, and code selection can be based on total time or medical decision making. If used by time, the professional who spends the majority of their face-to-face time reports the service. If we're billing by MDM, the practitioner who performs the problems addressed in the risk assessment reports the service. Documentation requirements must clearly reflect the substantial portion performed, include the management plan. One thing to note here is if you are going to bill by time, both the mid-level or resident must document their time, and the MD, the provider coming in and doing the attestation or the risk assessment, must also document by time. You both have to have your time documented in the provided or in the documentation to support billing by time. The one who actually has the highest level of time, that spends the majority of the time, will get the level of service billed to them. Here we just have some helpful documentation. So teaching physicians must be physically present during the services involving the resident or the student. They are responsible for verifying all documentation and ensuring the accuracy. Exams and medical decision-making, the teaching physicians must personally perform or re-perform the physical exam, the medical decision-making process. With that being said, you could also, the student or the mid-level could document and leave out the assessment and plan. And the provider could come in and make the assessment and plan, but make sure you are attesting that you did review the documentation from the mid-level. Statements should be, should confirm the presence during the service, verification of documentation, and agreement with the plan of care. Resident services, attestations must be added at the time of the signature. If present requirements are not met, billing is not permitted. So documentation must comply with CMS guidelines, obviously the TPR policies. This will help ensure accurate billing, regulatory compliance, and quality training. And it protects against improper claims and support educational integrity. This is kind of a crappy slide, but I will attach the TPR policy. These are actually examples of the teaching attestations and what is accepted. They can be used, for templates and macros. This one here is the TPR compliant chart completion. This goes over, and again, this article will be added as well as an attachment when I send over the slides. It's very vague here. They're very kind of, I tried to get them as clear as I could, but there's a lot more that actually goes into this one. So I will make sure that I attach them. Physician orders. Physicians must order all diagnostic tests and procedures for specific medical problems, and documentation must support the medical necessity. Vague statements like order labs are considered insufficient. Orders must be authenticated and clearly indicate intent. CMS does not accept tests not ordered by a treating physician. Missing backdated orders can result in payment denials. Exceptions exist, such as unassigned orders accompanied by signed progress notes indicating intent. Each order must include a diagnosis that supports the medical necessity of that order. Providers should refer to the Medicare benefit policy for details, requirements, and ensure compliance with documentation standards. So, for example, here, if you put an order in on the day, an x-ray, when you're seeing the patient, and as long as you put the results in your into your documentation that you reviewed and the results of that x-ray, you do not need to document a separate findings for the order, of that x-ray. You can, as long as it's in your documentation of the note that you are seeing the patient on that day, that you document the findings, you reviewed the findings, you reviewed it, and you list what the findings are for that x-ray, that actually covers you. Here are some definitions. The 2025 CPT includes updated definitions for various clinical terms that are used in E&M coding. Definitions clarify terms like minimal problems, self-limited conditions, stable chronic illnesses, acute complication injuries. Example would be a stable chronic illness is one expected to last at least a year, and stability is defined by treatment goals. An undiagnosed new problem with certain prognosis may indicate high morbidity risk. These definitions help standardize coding practices and ensures consistent interpretation across providers. Understanding these updates is essential for accurate documentation and billing. Providers should review the full list of definitions to align their clinical notes with coding standards. And here is some more of those definitions as well, and more. Independent interpretation means reviewing a test for which there is a CPT code and a provider providing interpretation that is customary for that test. You want to make sure a formal report is not required, but some form of interpretation must be documented. Again, that goes with, if you document it in your office visit note. Documentation must show the actual images or tracings were reviewed, not just the report. Give examples. So examples of statements like X-ray films reviewed by me. I reviewed CT, MRI, mammogram images, which demonstrate. So if the clinician reviews the images, tracings, and did not bill for the professional component, the credit for the interpretation. So a surgeon compares a mammogram, for example. Whoop, I don't know what happened there. Can you see my screen? Okay. So external records refer to documentation from another clinician or facility. These can include progress notes, lab reports, EMG results, or home health reports. Records from a physician, NP, or PA within your multi-specialty group count if they are from a different specialty. Do not include records from colleagues in your same specialty. Discussion requires an interactive exchange. Sending chart notes or having staff call another clinician does not meet these requirements. Independent historians can include or do include parents, guardians, surrogates, spouses, or witnesses, not other healthcare professionals. This is counted only once per encounter, even if multiple historians are present. There must be medical necessity, meaning the patient cannot provide a complete or reliable history. Simply having another person in the room does not qualify. Using a translator service does not count as independent historian. And this is classified, was added back in 2023. Here are some unique sources. So this again would be like for a lawyer, parole officer, case manager. You would need to document the reason for the discussion, person's name, the person's role, and the content. Here are some resources that we have in the TPR tenant policy job aids that go over certain, requirements if you ever get stuck or you need to know what the policy is. And that actually brings us to the end. So I can open it up to questions if anybody has any questions.
Hi, good morning. I was looking back at your when you presented the slide for E&M by time. I guess I haven't reviewed that in a while. It didn't look consistent with what I've been using. Can you go back to the slide with time for new patient?
Sure. Let's see. Let me get over there for you. Okay. So right here is, so this starts the slide. So, okay. What's the question?
The actual times that you put were different than what
Oh,
I've
the
been
time
using.
slides. Okay. I see what you're saying. Yes, this one.
So 99202, I thought that was 15 minutes.
No,
Oh, we have
so
to meet the
this,
threshold of 20 minutes.
yeah, you have to meet the threshold of 20 now. Yeah, so before they gave you like an increment to 15 to, I think it was 30 minutes. They have changed it. So now they're telling you they've given you just a standard time. So you have to meet 20 minutes or more.
And are we able to use the CPT code for the case manager being in the room with us?
That's a good question. I'm not sure. I can look that up for you, and when I reply and send this back, I can send that answer over to you. That's not a question that's ever come up before.
As far as medical students,
Mhm.
can they independently write a note? And as the attending physician, can we attest or modify that note alone, or does it have to be from a resident only?
No, you can modify it because you are going to be attesting that note. And which means that, you are agreeing with whatever they have documented as far as the findings or whatever. So you can make changes if need be.
So they can make an independent note that comes to me and I just do whatever, attest it, modify it, do whatever to that note.
Correct. Yep. As long as you are, you still make sure that you add your attestation in there that, you saw and agree with the residents' findings or whatever. You can make your changes in that note. Just make sure you are signing and dating it as well.
Okay.
Sorry, another question. I know you're not the biller, but do you know when we do the 57 modifier, do you
Mhm.
know how much our procedures get, or so when we use the 57 modifier, does that down code our visit or the procedure, and how much does that reduce the reimbursement by?
Well, I can tell you that it does down code it. I cannot, unfortunately, because we are, as coding educators, we are not allowed to talk to providers about work RVUs. So that would have to be somebody that, in the revenue cycle that would be able to answer that question as far as, how much. Um, but I can tell you that there is a minimal adjustment, yes, when the modifier 57 is there.
I guess since nobody else has any questions, those changes by time. So there was a change to the 99202 and a change to the 99213 and 99214. When were those made?
Those were made in 2024, January of 2024. No, even though I can tell you, even though you are actually, still using the old fluctuation, where they gave you a time range for the CPT codes, in reality, if you really think about it, they really are kind of still the same, really, if you think about it. So here, if you take your 99202, I believe the 202 said that you must spend a minimum of 15 to 29 minutes. So here they're just giving you that you have to have at least 20 minutes. So you still have your 29. If you met the patient and you did 29 minutes, you're still going to be at a level 2 because your next CPT code really falls at 30 minutes. So here for your 99203, you have to have a minimum of 30 minutes. But if you spend 40, you can spend up to 44 minutes. If you do 45 minutes, that's going to really bump you up to your level 4. So the time, even though you're looking at that time range, it still technically hasn't changed in the way that we're coding the level, but they're just, instead of giving you like your increment time frame, they're just giving you a basic minimum now. They're just showing the minimum of what you need to spend to be able to build that level. Does that make sense?
No, yeah, that does make sense. It's just the numbers were different in the past. For the follow-up, it was by every 10-minute intervals. Now, like 99213 used to, or 99214 could have been met by 10, 20. It used to be by 30 minutes, 99214 for follow-up, for example, but now you could make it by 25 minutes.
Yeah.
But what was that thing you said during the presentation? You said something about, well, you met at least half of it, so you could automatically go to a 45 minutes.
Yes. So, okay. So guidelines are now telling us, and this is something that just changed. I believe it's really coming up in the 2026 because it hasn't really been posted yet. But what's going to happen here is, so if you see a patient and you actually spend 42 minutes with the patient, you have actually spent more than half. Okay, between the allotted of the two. So they are going to tell you that you can go ahead and bump it up to the 45 because you're more than halfway there over the 30 minutes. So I believe it's going to be anything over 10 minutes from, like, say your 99203. You spent 40 minutes. So they're going to tell you you can go ahead and bump it up. Now, I personally would not do this as of yet until the guidelines come out for this, because what we're seeing right now, because CMS is making these changes, and unfortunately with the government shutdown, things have not been updated. So this was something that was made aware in our education that has come out recently. But because it has not been standardized and it has not been finalized yet, I don't think I would follow those recommendations as of yet. Until we go over the 2026 guidelines, come that time, I will address it with you guys. Because if there is a change, I really don't want you guys to go ahead and start following this process. And then because coding hasn't been updated and it doesn't have the final guidelines, because they do have to follow CMS guidelines. And if it's not written in, their formal, announcement, they're going to start suspending your claims. You really don't want that happening. So for now, just continue to do your standard, follow this protocol. So, if you see a patient for 38 minutes, you're going to want to make sure that you are billing at a 99203. Okay, because you have not met the 45 yet. So stay within that time increments. Any other questions?
Hi, Renee. This is Steve Slotkin. Just a quick
Hi, Dr.
question.
Slotkin.
Hi. Thanks for your presentation. You had mentioned in the medical decision-making section in the beginning about the different items you get for ordering tests and reviewing them. Just as a point of clarification, I think the majority of us would order at least an X-ray and then review it on the same day. We don't usually, I mean, we may look later at the radiology review, the reads, but we're always interpreting them ourselves. So are you saying that that counts only as one sort of piece of information, the ordering that we're doing and the interpretation that we're doing, as long as we document it, or is that two separate things, just to clarify?
So if you're reviewing it on a different date than the day that you ordered it, we can't count it, especially if it's done in your office setting, because we are billing out a CPT code for that X-ray, and it's a global CPT, which means that, the ordering, the reviewing of the X-ray and the interpretation, that actually is all included in that CPT X-ray code. So for you guys in your office, the majority of the time, not sure what happened there. So for you guys, when you're doing your office visits, most of the time you send the patient for an X-ray prior to, bringing them back. And, then when you're there with the patient and you're discussing everything and during the visit and you review those images, you technically can't get credit for any of that because we have a standardized CPT code to bill for that X-ray. Now, if you were to see the patient, say, on the facility side, and you ordered an X-ray, you're obviously not doing the interpretation because the radiologist at the hospital will be doing it. You would get credit for ordering that X-ray. Does that make sense?
Yeah, it does make sense. So
Okay.
basically, we're doing extra work and not getting credit for it is sort of the summation of what I'm gathering from you.
Unfortunately,
Okay.
yes.
Okay.
Yep. Any other questions?
And then I'll ask you one more question, Renee. So one of the things that we deal with in the pediatric side that we're I was trying to interpret from you is the like modifier 25. And so just to clarify, it sounds like the best way to kind of get quote unquote credit for that, to make sure you're doing the right thing, is to have sort of the E&M code have one sort of set diagnosis, and then whatever procedure you're doing is sort of a related, albeit potentially separate diagnosis. So the question that kind of we come into sometimes is, like, we'll be seeing like a baby for evaluation for some sort of like a foot deformity or something like that, and then end up having a club foot. And so parents don't want to wait to start casting. So we'll start casting in the clinic. And so potentially we're doing, a big H&P, physical examination, et cetera, finding out they have this. Instead of having them come back on a separate day to start casting, they prefer to start casting that day, which is a separate procedure. And so in the past, we would use that kind of 25 modifier, but they're typically using the same diagnosis. Should we be using some sort of all-inclusive diagnosis for like musculoskeletal screening in addition to that? Or how, like, what's like the ways of doing this?
So for those scenarios, it's a new patient coming in. It's not considered a planned procedure because you are assessing the patient. So the way you're doing those are correct. So for example, and education needs to go out, but so when the rod lengthenings, for example, the spine rod lengthenings, you do your procedure, they're within their 90-day global package, but they continuously come in, every 3 months or so to have, lengthening performed. Those are considered what we call planned procedures. And so in that case, this would be a reason with the modifier 25. So in that case, your previous note states patient to follow up, 2 to 3 months for another rod lengthening. Patient comes in, the documentation, supports the rod lengthening. You talk to the patient, you do the x-rays, patient's not having any complications or maybe some back pain, but that is all still included in that rod lengthening procedure. So therefore an E&M technically is not billable. An example for this would be if they come in for that rod lengthening, in the process of that, the patient had a fall and they're complaining of wrist pain. Now you evaluate that wrist at the same time, you do an x-ray, find out that the patient has a fracture of the ulnar. and you cast and treat that patient during that rod lengthening visit. That is technically a separate identified E&M. So you could bill, as long as your documentation supports both, you could bill the E&M for the fracture of the ulnar with a modifier 25 on the E&M and link that diagnosis to that E&M, and then bill your unspecified CPT code that we bill for the lengthening. We could bill that with the diagnosis for, whatever the reason, on the patient for the rod. That would be a scenario when you could bill separately.
Sure. No, I get all that. The only
okay.
question that's a little bit different is that these patients with the rod lengthenings you're referring to, and I get the example, is that they're postoperative spine surgery patients. So if we did a fusion, for example, on a patient, we see a patient in follow-up based on their surgical follow-up. We're still evaluating them based on their complications from surgery, their incisions, how they're healing. So in a sense, these are all separate procedures for the lengthening that we're doing, which is sort of the way we've been trying to do it to document it, is saying that they're following up postoperatively. Like, we still have to manage their postoperative complications, make sure the screws are in place, the rods are in place, everything is fine, they're doing okay, they don't have increased complications, neurologic problems, etc. No increased back pain or other things. So we're evaluating them for a postoperative setting, and then as
Right.
part of that, separately, they're having lengthening of their rods, which we used to do intraoperatively. So whether there was, like in the past, for example, we would use these traditional growing rods where you'd have to go surgically to do it. So every postoperative visit would be just a normal postoperative visit like we do with fusions. So I know what you're saying, but I'm still trying to understand, like, I'm still trying to understand, because like there you can make the case that that we're making a postoperative visit. And so because it's a postoperative visit, it's still a kid with scoliosis who had surgery. So how do we document or indicate that it's technically an evaluation of them for one problem, and then, oh yeah, we're doing a procedure that's related, but it's not the same problem that we're seeing them for, even though it's planned.
Right. So here, yeah, we just had this is a very touchy subject right now in the orthopedic group. So the problem here is CMS defines, and I know what you're saying, because you guys are still evaluating the patient. You are, making sure it's not like you're just, the patient's coming in, you're adjusting the rod and then sending them on their merry way. You're still, talking to the patient, reviewing x-rays, things like that. But Medicare actually considers that all part of the planned procedure. So when you see this patient and your documentation states, patient to return in 2 to 3 months for, an adjustment on the rod, they actually consider, whether you're doing those x-rays, whether you're talking to the patient and addressing, their back pain or whatever, they still consider that all part of that rod adjustment, because it's a planned procedure to them. And that's where I think the frustration is coming from. We just had a really huge topic on this last week, in regards to this. And unfortunately, there is no way around these guidelines unless it's a separate identifiable problem that
Sure.
you're
So
treating
yeah,
the patient.
makes sense. Along those lines, so like that gets to the beginning of my question, which is it more helpful then in these cases with these modifier 25s to include some sort of separate diagnosis? That's what I was trying to figure out.
Well, it's got to come, I mean, so with your new patient, for example, like you stated with the club foot, that is a new patient that's coming in that you have never seen before, chances are, because you're addressing it and then you determine that the patient's got the club foot. You're doing all that workup of a new patient to assess the problem and for a definitive diagnosis, and you make those recommendations. So I understand what you're saying, because you hate to have the patient come back. I mean, if the patient's there, you might as well start doing what you need to do. And that makes perfect sense. And in that perfect world, you don't need 2 separate different diagnoses to be able to build that E&M along with the casting. That right there is considered separate, identified, because it's a new patient and you're just determining now. Now, if the patient were to come back for the casting, a follow-up casting, and you recast the patient, again, that's a planned procedure. So you're only going to bill for the procedure portion that you did. Unfortunately, I can't give you direction to say use a different diagnosis to be able to support an E&M, because that technically, to me, we can't give you those guidelines. It would have to be something under your assessment to
Understood.
determine whether or
Yeah.
not.
I got you.
Just a question about your future talks, and maybe you can build it in. Can you at some point discuss billing from the observation and the emergency department for us? For example,
Sure.
if we see a patient and we don't know if they're going to be admitted or not, can you go over how if those are supposed to be um, outpatient or inpatient visits in the future, or whether those are supposed to be consults?
Well, I can tell you, so if you're consulted to come down while a patient's in the emergency room, you would bill your E&M level as a new patient visit and in an outpatient setting. So your 99203, 204 codes. If you're unsure if the patient's going to be admitted to observation. Now, with that being said, if you see a patient in follow-up, they still have not been admitted to observation on the following morning, you would actually bill your established patient at that point, especially if you're following up from the day before, why they were in the ED when you were consulted. As far as observation goes, the observation codes are only going to be used by the provider that actually is admitting them to observation. All other providers that are seeing a patient would actually bill the outpatient CPT codes.
So if let's say I see somebody in the emergency department and then they get admitted, after I've sort of already written my note and stuff like that, does that automatically get converted to an inpatient E&M?
Yes, that is correct. So in that case, when coding receives the documentation or the charge for the visit, the one thing that they always look at is where the status of the patient was. So if they were originally seen in the ED and several hours later they decide to admit the patient, the ED provider decides to have the patient admitted, that's going to change your CPT code. And that would be crosswalked, what we call a crosswalk. So if it was like a 992, say a 214, we would crosswalk that to a 9923, 222 for you. Because the patient technically is now considered inpatient. So the status, when it changes like that, CMS makes us bill by the status that the patient, how can I explain this? So the way we bill this is, even though the patient was in the emergency room, in the status change to inpatient, Medicare's guidelines tell us that we have to bill it under inpatient, even though you may have seen the patient while they were in the ED. It changed, the patient status changed to inpatient. So we would crosswalk that code to inpatient for you on the back end. Does that make sense?
Yeah, that makes sense.
Okay.
I noticed on my billing, there's actually, for most of us, I don't know if you know, but for most of us, a lot of our billing we don't actually do ourselves. Our coding, I should say, a lot of our coding we don't do ourselves. I've noticed that for some patient evaluations, I get credit for a consult, and some of them I don't. Do you know under what conditions
Yeah.
bill for a consultation?
So the reason being, Medicare, Medicaid, a lot of your umbrella plans to Medicare and Medicaid do not accept consult codes anymore. So, but some of your commercial insurances do, like for instance, Blue Cross Blue Shield. So if a patient has Blue Cross Blue Shield and you were doing a consult, you were requested for a consultation, then we would bill that consultation CPT code for you. But if it was a Medicare patient and you were consulted, unfortunately, we have no choice but to bill that as an inpatient, an initial inpatient CPT code if they were inpatient, or it would be crosswalked to an outpatient code depending on the status of where the patient was. Yeah, unfortunately, CMS have done away with consult codes, and I want to say it's probably been years now. And, you know, whoever follows, most of your government insurances and things like that will follow Medicare and Medicaid's guidelines on this. But again, like I said, your commercial insurances, some of them do not. They still allow for consult codes. So that's probably why you're seeing that, you know, some are billed and some are not. It's insurance driven. Any other questions?
Thank you for your time today, Renee. Appreciate everyone joining. We'll have our next session December 19th for surgical coding, and we'll look forward to it.
Sounds good. Thank you for having me. Again, I will go ahead and send this over. Should I send it over to you? The
Yes, you can send
presentation
it
and
to me.
then
Yep.
some of the, okay.
Yep.
Okay. If anybody has any questions on the first slide, my email is there, my email address, my cell phone number is there. Don't hesitate to call or email me with any questions or concerns you might have.
Thank you. Yeah.
Excellent. Thank you.
All right.
Thank you. You guys have a wonderful
you.
day.
Thank you.
Thank you, Renee.